Good afternoon. My name is Anett Rancz, and my thesis is the invisible presence of microscopic colitis. I am finishing my first year of the PhD training in the gastroenterology and endocrinology group of the CTM. Likewise, my 12-month fellowship program provided by the Mo Foundation for the Community, and for that I would like to thank this opportunity. In my vision, some vigilant physicians educate patients to prevent the development of the disease microscopic colitis. For that, my mission is providing professional knowledge about the clinically relevant risk factors of microscopic colitis. I have two ongoing projects. My first topic, microscopic colitis, is a risk factor for low bone density. In Europe, the prevalence of microscopic colitis is around 119 cases per 100,000 persons. There are many confounding factors regarding the relationship of microscopic colitis with low bone density. First of all, both diseases are more frequent in elderly women. Moreover, menopausal women can receive hormonal substitution therapy, which in turn can cause microscopic colitis. Furthermore, budesonide, the gold standard therapy of microscopic colitis, is a corticosteroid with low systemic bioavailability due to its high first-pass effect in the liver, but still it has been implicated in a long-term therapy in the development of low bone density. So we aimed to scrutinize if microscopic colitis is a risk factor in the development of low bone density. You can see our clinical question, and we applied two frameworks, the PECO and the COCOPOP. We made our systematic search on the 16th of October 2021 with the search key constructed from two main parts. The first part contained microscopic colitis and the three subtypes of it, while in the second part we included osteoporosis and the synonyms of it. We made our search in 5 databases, and we got around 3,000 hits. And the number of included studies in this review was 4. Our first outcome is if microscopic colitis is a risk factor in LBD development. We investigated MC patients compared to age and sex-matched controls with 37% moderate heterogeneity, suspecting that it is due to the Rancz study, which has a cross-sectional study design with the youngest and the smallest number of patients. In our overall measurement, the odds ratio was 2.13, which means that the presence of microscopic colitis doubles the odds of low bone density. We made additional analysis where we omitted the Greenberg study, which is only a conference abstract, and it resulted in a 2.96 odds ratio, which means that microscopic colitis triples the odds of low bone density. In our proportional analysis, we investigated bone mineral changes in the MC population. Low bone density has two forms. The mild is osteopenia, and the severe form of it is osteoporosis. Its clinical relevance is that osteoporosis can culminate in osteoporotic fractures. So we investigated MC patients with low bone density with a 75% considerable heterogeneity, presumably due to the Greenberg conference abstract, which has the oldest population. The overall proportion was 0.68. We have MC patients with osteopenia, and the proportion was 0.51, and MC patients with osteoporosis, and the proportion was 0.11, which means that 2/3 of the MC population have low bone density, half of them have osteopenia, and 1 in 10 MC patients has osteoporosis. All of our outcomes are at a very low level on the certainty of evidence scale after the Grade Pro guideline due to the small sample sizes and because the included studies use the surrogate outcome measuring bone mineral density. The strength of our work is that this is the first comprehensive study regarding the relationship of microscopic colitis with low bone density. All the included studies used DEXA to measure bone mineral density, and we applied a rigorous methodology. But we have limitations as well, like a small number of studies with different study designs, low number of patients, and the female predominance. Eventually, we did not have enough data to calculate the pooled adjusted odds ratios. In conclusion, our data suggest screening patients with microscopic colitis for bone mineral density at the moment of diagnosis. Based on our findings, we can recommend lifestyle and dietary changes in case of osteopenia, calcium, and vitamin D supplementation. And we also recommend impact exercise combined with resistance training because it was shown that this fits the best for pre- and postmenopausal women to maintain their bone mineral density. Regarding implications for research, further prospective observational studies, incidence studies are needed, and we want to highlight the importance of international and national registries with bone mineral density follow-ups. We traveled a long way with my team, but right now we plan to submit our journal to the Frontiers our paper to the Frontiers Medicine journal. But in the meantime, we are harvesting the fruits of labor, and we are gaining experience by attending various conferences. Microscopic colitis is a really underdiagnosed disease, and we suspect that this might be one reason for the small sample sizes in our previous analysis. Furthermore, as I have mentioned, one limitation was that most of the studies lack in confounding factors, which might be also the risk factors of microscopic colitis. Thus, we aimed to investigate these aspects of the disease. Just a few words about the background. In Europe, the incidence of microscopic colitis is around 11.4 cases per 100,000 person years. Medication use has been implicated in the development of microscopic colitis, while the body mass index is inversely associated with the risk of microscopic colitis. So our aim is to assess the risk factors of microscopic colitis in adult patients. Our hypothesis is that in the presence of the risk factor, the odds of developing microscopic colitis are higher. We applied the PEO framework, and our clinical implications are screening and prevention. We made our systematic search on the 18th of December 2021 with the search key containing only microscopic colitis and the 3 subtypes of it in 3 databases, and we got around 5,000 hits. We are right now ready with the data extraction and the risk of bias assessment, but we need further discussions because it's a really various data. My plan is to submit my second study during autumn this year, and I would like to close my presentation with the words of a great singer: "There are no shortcuts to any place worth going." Thank you, and if anyone has questions, I'm here to discuss them.
Very nice presentation. Congratulations, Anett. I have a question regarding your first project, because you mentioned the limitations that you cannot assess the overall pooled ratio, the adjusted pooled ratios. Were you able to investigate at least the confounding factors?
Thank you for your question. One study mentioned confounding factors, and there was an adjusted odds ratio. We had one number, but we could not use it because the other studies lack in confounding factors, so we could not pull it.
My question is regarding your first project. Maybe I just missed it. What was the proportion of females and males in the study?
Actually, I haven't mentioned it, but most of the studies has a really big proportion of female participants, like almost more than 80%.
And what is the known gender distribution of microscopic colitis?
It is much more higher, the prevalence of it in the female sex.
Thank you for your presentation. Can you please tell us a bit about your second project's results or preliminary results? Like, what did you find, like this female predominance?
Yes, thank you for your question. We have several reports. We have really big cohort studies that are actually national US reports where they are investigating nurses' health participants of nurse health system, and they included only female subjects. So these cohorts are with the biggest study participants, but they are only female participants. So we probably won't be able to pull them together with the other studies. And furthermore, we have a lot of case controls as well, mostly in case of medication use, where they are comparing them with age and sex-matched controls. The use of medications, for example, for PPI use, for NSAID use, and for SSRIs. There are also really small studies, like with 26 participants, where they are investigating infectious factors as a risk factor of microscopic colitis. And there are also social economic factors, was surprisingly, and also origin.
Any other question? I was going to ask you about medications, but you mentioned an important group is PPIs. Besides PPIs, what other medications put you at risk to microscopic colitis?
In the guideline, the PPIs, the SSRIs, and the NSAIDs are mentioned, but besides that, they are investigating like beta blockers, antihistaminics, and but there are still a few.
Okay.
And there are also subgroups where they are investigating different types of PPIs. For example, lansoprazole, omeprazole, and so on.